Welcome to the Optimity Advisors Integrated Healthcare webinar series. This is webinar 4 of our 5-part series on integrated care. My name is May Weber. The first webinar introduced the series and focused on why integrated care has become the policy and implementation priority it is today in many health systems. In the second webinar, we covered the different contexts in which integrated care flourishes, using examples from across Europe. The key message: there is no one single way to develop and deliver a successful system of integrated care. But focusing on the objectives of better health and care rather than cost reduction is critical. The third webinar considered the different classifications of the mechanisms through which integrated care is delivered and how these might be impacted on by system moderators. In this webinar, we will be talking about implementation issues around integrated care. We will explore common barriers and how to overcome them and identify enablers to make change happen. We have seen in our earlier series that integrated care in its various forms produces benefits such as quality enhancement, increased system efficiency and cost reduction, higher patient and staff satisfaction, and better access to care. However, more often than not, the integration of care faces barriers. These are caused by contextual, institutional, and professional factors within the different domains of integrated care. So what are the most common barriers that arise when attempting to deliver integrated care? A meta-analysis of 914 academic articles yielded 6 key barrier domains. The order represents the frequency with which they were identified: administrative or regulative, funding, interorganizational, organization structure, service delivery, and clinical delivery. Administrative and regulatory barriers occur with the highest frequency. These can be due to national borders. By that, I mean the borders of neighbouring territories can act as barriers to the integration of care due to differences in healthcare systems and languages, as well as past historical development. They can also be due to regulations. Existing regulations can impede interorganizational collaboration, either by forbidding it or making the implementation process extremely complicated, costly, and time-consuming for the partners involved. Legal requirements can also hamper the exchange of information, for example, of patient data, which is needed to enable planned interorganizational collaboration, or they can provide obstacles to the pooling of budgets in the public sector. The next barrier we'll look at concerns the lack of organizational resources and external funding. Sometimes organizations lack the resources needed to initiate and develop interorganizational collaboration. Organizational managers are often unable to invest necessary resources, like the time to develop a collaboration, due to competing priorities. Furthermore, they fear cost shifting connected to the entry into interorganizational collaboration, for instance, through decreased governmental support in the public sector. Now we will look at barriers related to the interorganizational domain. Strong leadership is important for conducting collaborative activities. If organizational leaders start to protect their territory against the collaboration, the progress of collaboration can be affected considerably. This can also be the case when more planning takes place than implementation, which can lead to overprocessing without any output on the level of care. With regards to missing actors, the lack of important actors can be a barrier to successful collaboration in a certain nexus of health service delivery. For instance, the failure to include a local hospital in our network of integrated care can cause complication. In the case of power imbalances, Organizations often start to defend their own resources and authority, which often leads to power conflicts. Also, misalignment of expectations around the vision of an interorganizational collaboration can lead to controversy. Differing organizational structures and processes can impede interorganizational collaboration. Furthermore, within different organizations, there are often divergent formal timelines, views about employment and accountability, and hierarchies exist. These all have an effect on interorganizational collaboration. Now we will look at the barriers related to the organizational domain. Organizational versus collective interests. Typically, organizations calculate and pursue their own interests versus the collective interest. If these interests are conflicting, barriers impeding the interorganizational collaboration emerge and conflicting agendas arise. Organizations develop their own specific cultures, which can create barriers to interorganizational collaborations if the differences between them are not managed appropriately. Prior experiences of cooperation influence both the willingness of organizations to collaborate and also their behavior within existing collaborations. If they have experienced former collaborations, organizations assess cooperation outcomes differently. Now we will look at the barriers related to service delivery. Collaboration that requires the use of common IT infrastructure faces formidable challenges with regards to the lack of interoperability. The existence of different IT systems typically complicates data exchange and can act as a barrier to interorganizational collaboration. Interorganizational collaborations do not materialize, are hampered, or fail if one partner has little trust and understanding of the goals, procedures, and behavior of the others. Insufficient dialogue between organizational partners can also impede collaboration. What's more, a lack of communication can lead to ambiguities in responsibilities and the aims of the overall collaboration. It is common to resist change. Often, organizational members are not willing to accept changes connected to the implementation of interorganizational collaboration, especially if they do not see the value of the collaboration or fear the loss of their own professional expertise. Within interorganizational collaborations, more often than not, individuals with different professional backgrounds, for example, doctors, nurses, and managers who were educated in business skills, have to work together. These differing backgrounds of healthcare employees can hamper collaboration. Established hierarchies between professions such as doctors and nurses, as well as power structures, can also be a constraint to interorganizational collaboration. The last barriers we will look at relate to clinical delivery. There can be issues around confidentiality. Previous studies have reported that confidentiality issues can impede interorganizational collaboration, leading to a lack of shared information about particular patients. This barrier has been highlighted in studies on the provision of integrated mental health care. In particular, a lack of information exchange, which is closely related and sometimes caused by confidentiality concerns. A lack of information exchange can hinder joint working across organizations. Inadequate information could, for instance, concern results from prior diagnostic tests and imaging, or the medical regime of patients during referrals. So now we've identified the main barriers. How can we overcome them? I will now introduce an existing tool, a repository, and initiatives that can help organizations or health systems to overcome barriers, identify enablers or facilitators, and thus make change happen. A useful tool is the Scirocco Maturity Model for Integrated Care. Scirocco offers a tested, self-assessment tool to facilitate the scaling up of integrated care implementation. The maturity model includes 12 domains: readiness to change, governance, information and e-health systems, finance and funding, standardization, the removal of inhibitors, a population approach, the empowerment of citizens, evaluation, the breadth of ambition, the management of innovation, and capacity building. Collaborative partners in an integrated care initiative, these can be existing or foreseen initiatives, can assess their progress against these 12 domains by scoring 1 to 5 depending on their level of implementation. Through discussion, the individual reasoning behind each self-assessment can be understood, and a collective agreement reached on where the system is in the implementation journey. This allows for the development of a plan to move forward. Repeating the assessment several times allows partners to monitor progress, assess barriers, identify success factors, and review plans for future implementation. The use of the Scirocco tool is helpful because it allows us to consider the initiative's contextual factors. As we learned in Webinar 2, the context in which the Integrated Care Initiative is implemented is very important, and the systems need to adapt to their own context. The study we carried out for the European Commission is also of value. Funded by the EU Health Programme, the study aimed at reviewing the progress on integration of care at national and regional levels in the 28 European countries plus Norway and Iceland. We did this by analysing the level of penetration or adoption of integrated care models in health systems, and by analysing the readiness of health systems to successfully implement integrated care. The results of this extensive mapping exercise have been compiled in a repository containing 546 initiatives. The repository offers a rich source of examples of integrated care initiatives that can be used to support implementation by looking at what is happening elsewhere in Europe, and the different approaches that these models or programs have taken along with the solutions that they have adopted. There are other initiatives and organisations which offer support to the implementation of integrated care. Here we will provide a few examples. The International Foundation for Integrated Care offered training, resources, and organised an annual conference with the aim to lead the global movement for change by moving the integrated care agenda forward. The European Innovation Partnership on Active and Healthy Aging have an action group dedicated to integrated care. FIGURE is an EU project that offers support to the transformation of health and care systems, the provision of sustainable models for care integration, and to facilitate identification of best practice and evidence-based guidance for scaling up. Also funded by the EU Health Programme, Scirocco has now launched a new initiative, Scirocco Exchange. The project aims at developing the maturity model into a validated and self-assessment tool that will facilitate the successful scaling up and transfer of best practices in integrated care across the European regions by matching their complementary strengths and weaknesses. Thank you very much for your valuable time. In our next webinar, the last of our 5-part series, we will be discussing the performance assessment of integrated care and why it is important in the evaluation of new models of care. We will talk about the difference between measuring maturity of integration and performance, and we will introduce the performance assessment framework and tool we have developed for the European Commission. This webinar will now be followed by a Q&A session. However, should you wish to contact any of our team directly to discuss any of the content presented in this series, or if you would like to have more of a general conversation about integrated care, you can find our email addresses here on the screen. Thank you again for your valuable time.